Welcome to this episode. Today, we're diving into a detailed pediatric cardiovascular quiz prep that covers a broad range of topics, from cardiac diagnostics and congenital heart defects to heart failure, hypoxia, postoperative care, and even shock management. It's designed for clinicians with solid expertise, so we'll focus on the clinical reasoning and nuanced nursing priorities behind these concepts.
Yeah, it's a dense topic, but really important. Pediatric cardiology nursing demands a deep understanding of pathophysiology and practical interventions, especially when you're preparing for exams or clinical practice. So let's start with cardiac catheterization prep. The priority nursing action is maintaining NPO status. That's to prevent aspiration during sedation, which is a critical safety step.
Right, and it's interesting because sometimes people might think encouraging oral fluids is helpful before a procedure, but here, NPO status trumps that. It's all about minimizing risk during sedation.
Exactly. And then post-catheterization, the key finding that requires immediate action is a weak distal pulse. That's a red flag for vascular compromise at the insertion site, which can quickly lead to ischemia if not addressed.
Yeah, mild bruising or sleepiness are expected post-procedure, but a weak pulse demands urgent evaluation. It's a subtle but crucial distinction.
And when it comes to reducing anxiety before cardiac procedures, allowing parental presence is the best intervention. Family-centered care really shines here, because it reduces stress and improves coping for the child.
Definitely. Restricting communication or delaying preparation only adds to anxiety. So moving on to hemodynamics and congenital heart defects. Understanding shunt physiology is fundamental.
For sure. Left to right shunts, like an atrial septal defect, cause increased pulmonary blood flow because oxygenated blood from the left heart recirculates to the lungs. This can overload the pulmonary circulation and lead to congestive symptoms.
And the plumbing analogy really helps here. Think of left to right shunts as a leak in the plumbing that causes excess water flow to the lungs, stressing the system.
Right, and in contrast, defects like tetralogy of Fallot cause decreased pulmonary blood flow due to right ventricular outflow obstruction. That's like a detour sending unfiltered water directly into the main supply, which in this case is systemic circulation, causing cyanosis.
That's a great way to visualize it. And the most common congenital heart defect is ventricular septal defect, which is a left-to-right shunt increasing pulmonary flow.
Yes, and cyanosis occurs when deoxygenated blood bypasses the lungs and enters systemic circulation, typical of right-to-left shunts or mixing lesions.
So understanding the direction of the shunt really guides both symptomatology and management.
Absolutely. Now, when we look at heart failure in children, structural defects are the primary cause, unlike adults where ischemic causes dominate.
That's a key point. And the main therapeutic goal is to decrease cardiac workload. We do this by managing preload and afterload and optimizing contractility.
Digoxin is the go-to medication to improve myocardial contractility, enhancing cardiac output. Meanwhile, diuretics like furosemide help reduce fluid overload, but fluid restriction monitoring is essential to avoid volume excess.
And encouraging rest while limiting activity reduces oxygen demand and cardiac stress, which is critical in managing pediatric heart failure.
Moving on to hypoxia and cyanotic spells, hypoxemia is defined as low oxygen saturation, not just low hemoglobin or heart rate.
Right. And in tetralogy of Fallot, hypercyanotic spells, or TET spells, are acute episodes of profound hypoxia due to increased right-to-left shunting.
The immediate nursing intervention is placing the child in the knee-chest position. This increases systemic vascular resistance, reducing the shunt and improving pulmonary blood flow.
That's a life-saving maneuver. And clubbing of the fingers indicates chronic hypoxia, reflecting long-standing oxygen deprivation and compensatory peripheral changes.
Exactly. After cardiac surgery, respiratory status is the priority assessment because of risks like pulmonary complications and airway compromise.
Promoting rest post-op reduces cardiac workload and supports recovery. Stimulating the child or encouraging crying can increase oxygen demand and should be minimized.
Family support is also integral. Nurses must provide education and emotional support, offer consistent updates, and actively involve parents to improve coping and outcomes.
That's often overlooked, but makes a huge difference in the child's and family's experience.
Now on infective endocarditis, it primarily affects the endocardium, especially damaged valves, and requires prolonged IV antibiotics targeting the causative bacteria.
And rheumatic fever follows untreated group A streptococcal pharyngitis, potentially causing rheumatic heart disease with permanent valve damage.
Distinguishing these conditions is critical for management and prognosis.
On the topic of lipids and hypertension, targeted cholesterol screening is recommended for children with a family history of heart disease, emphasizing early risk identification.
Pediatric hypertension is defined as blood pressure above the normal range for age, sex, and height, so careful monitoring is essential.
Kawasaki disease is an acute vasculitis affecting medium-sized arteries, notably the coronary arteries, with coronary artery damage as the main complication.
Early recognition and treatment are vital to prevent aneurysms and long-term cardiac morbidity.
Finally, shock results in decreased tissue perfusion, leading to cellular hypoxia and organ dysfunction.
In anaphylaxis, epinephrine is the first-line treatment, rapidly reversing airway edema and vasodilation.
An early treatment of septic shock includes administering broad-spectrum antibiotics within 1 hour to reduce mortality. Delays worsen outcomes.
So, to wrap up, the clinical reasoning behind nursing priorities, like why NPO status is critical pre-catheterization, or how shunt physiology guides symptoms and interventions, is essential for effective pediatric cardiac care.
Absolutely. In integrating family-centered care, recognizing urgent signs like weak pulses or cyanotic spells, and timely management of shock states all contribute to better outcomes.
This episode should give clinicians a deeper understanding of pediatric cardiovascular nursing priorities and the pathophysiology that underpins them.
Thanks for joining us in this detailed discussion. We hope it helps sharpen your clinical judgment and knowledge.
Take care.